Pathology Review for the Dental Hygienist is presented by Carol Barr Overholt, RDH, Specialist in Oral Pathology and Professor at Niagara College School of Dental Hygiene.
Hello, my name is Carol Barr Overholt from the Dental Hygiene Program at Niagara College. Today I'd like to review with you some of the common and not so common oral pathological lesions found clinically. In many cases, a client's history, both dental and medical, will help you to assess the lesion and make recommendations to your dentist. The only way to provide a definitive diagnosis in many of the conditions you're going to see today is to refer a client to an oral surgeon for a biopsy. Understanding the oral pathological lesions in today's presentation will help you with client discussion regarding the conditions in their mouth. It will improve the client's confidence in you as a clinician, and it will ultimately improve your client care. I hope you enjoy the presentation you see today and find it helpful in your day-to-day practice. Instead of classifying the lesions we're seeing today by color or descriptive terms, I've grouped them by origin or cause or common pathology. This will help the clinician keep his or her focus on the diagnostic possibilities and improve the differential diagnosis process. The first group of lesions we're going to look at are those classified as variations of normal. Although they are not pathological, they need to be identified and ruled out as pathology so as not to confuse the diagnosis. Fordyce granules are normal ectopic sebaceous glands. They present in 80% of adults and are seen in the superficial tissue, commonly found on the lips and buccal mucosa. They're asymptomatic and require no treatment. Melanin pigmentation is seen in persons of color. It's usually found on the gingiva or oral mucosa and requires no treatment. The reason it's important to identify melanin pigmentation as normal is that there are some conditions that present, particularly Kaposi sarcoma, for example, with changes to the pigmentation of the gingiva. Leukoedema is another normal condition characterized by generalized opalescent qualities to the buccal mucosa. It's seen in up to 85% of the black adult population. The opaque quality disappears when the tissue is stretched. It is benign and again requires no treatment. Linea Alba literally means white line and is found as a unilateral on one side or bilateral on both sides of the buccal mucosa. It generally follows the occlusal plane and is often seen in clients who clench or brux. The upcoming lesions are classified as benign idiopathic lesions. That means they are of unknown origin and are very likely not pathological. They are investigated as possible pathologies until a definitive diagnosis is made. Biopsy may be required, but ultimately they are rarely treated and considered normal for that client. The first benign idiopathic lesion is seen very regularly. It's referred to as Geographic Tongue and is also known as benign migratory glossitis. The cause is unclear. There does seem to be a familial predisposition, and so there is the question about the genetic factor. Some studies support histologically that this lesion is similar to psoriasis. It may present as either erythematous patches with a white or yellow border or shiny patches. The patterns change. There are periods of remission and exacerbation, meaning it gets worse and gets better. That's why it's referred to as migratory, because the pattern changes. Some studies suggest that it is made worse by stress. The clients may complain of a burning sensation, particularly in the presence of certain foods. Treatment is usually not required. Median rhomboid glossitis presents as a diamond or rectangular shape in the center of the posterior of the tongue. It looks denuded or shiny and is red. If the rest of the tongue is coated around it, the contrast makes the image more noticeable. That coating may be caused by Candida albicans or candidiasis. An antifungal may be prescribed, or it may resolve on its own without any treatment. Hairy tongue is a condition where the filiform papillae of the tongue increase in keratin development and lengthen, hence the term hairy. It may clear up on its own and can return. It's white if it's unstained. If chromogenic bacteria become embedded in the filiform papillae, they may stain the tissue, causing black hairy tongue. Food or tobacco may also stain this tissue. The treatment for clients is to brush gently with a wet toothbrush to dislodge any underlying bacteria and to try and get rid of the condition. Fissured tongue is another benign lesion. It's also known as scrotal tongue because of the deep fissured grooves on the dorsal surface of the tongue. Again, there's a familial predisposition. Approximately 5% of the population present with this, and really the only cause for concern with fissured tongue is that food bacteria and plaque may become trapped in the tongue and causes sensitivity. Again, the treatment is to brush the tongue and keep the grooves free of debris. The following conditions have bacteria as a source of infection. Some are treated and others resolve on their own. As we move through the lesions, we'll identify those that may require treatment and what may be prescribed for them. The first lesion of bacterial origin that we're going to discuss is necrotizing ulcerative gingivitis, commonly known as NUG. The bacteria that produces this infection is the spirochete Borrelia vincentii, and some fusiform bacilli have been implicated as well. This condition is associated with impaired resistance to infection. The client will present with painful, punched-out papillae, a necrotic slough over the gingival surface, fetor oris, and/or a metallic taste. If the condition is severe enough, the client may also present with systemic symptoms, fever, lymphadenopathy, and a generalized malaise. Although tuberculosis was considered for many decades a disease of the past, it has had a resurgence, and more clients may present to your clinical practice harboring this bacterium. It's caused by Mycobacterium tuberculosis and presents as a primary lung infection. The incidence of tuberculosis is on the rise in Canada due to the fact that it has become resistant to many of the traditional treatments. Although oral lesions are rare, they would present on the tongue and palate. They will be painful and fail to heal. Another infectious disease that is on the rise and difficult to treat again because of resistance is syphilis caused by Treponema pallidum. It's usually sexually transmitted, but direct contact is also possible. The treatment is antibiotics. The physician and dentist may have to try several antibiotics to get this condition under control due to the bacterial resistance to the traditional antibiotics. It progresses through in 4 stages. A primary stage where your client will come into the office with a chancre, which is highly infectious and often seen on the lip. In the secondary stage of syphilis, a mucus patch will develop somewhere within the oral cavity. In the latent stage, where it goes into a dormant stage for some period of time, the client will present with no symptoms. In the tertiary stage, the client will present with a gumma, which is a large hole. It often presents as an oral antral fistula. Actinomycosis is caused by Actinomyces israelii. These bacteria are also found in the normal oral ecosystem like yeast. Scientists are unsure why some clients develop a disease from them. A draining abscess is the usual presentation. Within the abscess pus, bacterial colonies will be seen as bright yellow granules. That is one of the defining diagnostic criteria. The treatment: high doses of antibiotics over a long term. Impetigo is seen as a common dermatologic infection. It can be caused by either Staphylococcus aureus or Streptococcus pyogenes. Bacteria present on the skin. In order for an infection to take place, broken skin must allow the bacterium to enter the system. It will present as vesicles or bulli, clinically resembling herpes simplex. Systemically, the client may again have a malaise or a fever or a lymphadenopathy. The treatment is topical or systemic antibiotics. Lesions of viral origin are going to become increasingly important to us because of the rise of HIV/AIDS, which I'll discuss at a later point. The first lesion we'll start with is herpes simplex, seen in about 1/3 of the adult population. Primary herpetic gingivostomatitis is the condition where the client is first inoculated and has their first oral outbreak. Recurrent herpes simplex infection are the lesions that plague us through our adult life and often present on the lip. The cause is the human herpes virus group, HHVs for short. The original outbreak will be painful with erythematous, rupturing ulcers. Later in life, clients will tell you that they have a tingling feeling in the lip or a slight itchiness on the area that the lesion will break out on. This group of lesions have a virus as their source of infection. They may be either treated with antivirals, not treated at all and allowed to resolve on their own, or the symptoms may be treated for comfort. You've probably heard lately on the news that the human papillomavirus has been implicated in cervical cancer. Of interest, it presents orally. You may contract this virus through direct or sexual contact. It presents as small projections of keratotic epithelium with an underlying fibrous connective tissue layer. Clients may self-inoculate the oral region by biting a finger with a wart on it. The treatment is surgical excision or cryotherapy. Histofreeze is an example of a professional cryotherapy agent. Varicella zoster virus, or VZV, is the cause of chickenpox and later in life a reemergence of those chickenpox called shingles. It's a contagious condition. Herpes zoster is a common form of adult oral lesion. Vesicles form along the cranial or sensory nerve pathway, often unilaterally. This condition may accompany immunodeficiency or some blood and lymph malignancies. Varicella zoster viruses may resolve on their own. If not, antiviral drugs, systemic or topical steroids may be used to treat the neuralgia. The Epstein-Barr virus is the cause of hairy leukoplakia. Because of the Epstein-Barr virus's link to Burkitt lymphoma, nasopharyngeal cancer, infectious mononucleosis, and hairy leukoplakia, particular attention must be paid to the diagnosis of this lesion. It's often seen in clients with HIV/AIDS and presents as a white, irregular, roughened or corrugated lesion. It's found on the lateral border of the tongue. Something of interest for the clinician. Oral hairy leukoplakia and candidiasis seen together in the mouth are considered predictive of AIDS and require investigation. The client should be referred to the family physician for follow-up. The next condition, herpangina, is caused by the Coxsackie virus. This virus was given its name because it was first identified in Coxsackie, New York. It's transmitted through saliva, through an oral fecal contamination, or a respiratory aerosol. It will present as fluid-filled vesicles on the soft palate. It produces painful swallowing, redness, and pharyngitis may also be present. The condition usually resolves on its own within 7 to 10 days. The lesions we're now going to look at have fungus or yeast as their source of infection. Although fungus is a normal component of the oral ecosystem, in these cases it represents an overgrowth due to some kind of underlying condition. As you'll likely notice, many of these conditions are associated with a suppressed immune system. As you'll likely notice, many of these conditions are associated with resistance or a compromised immune system. They could actually be classified as immunosuppressive conditions in many cases. The drugs of choice for fungal overgrowth will likely be topical or systemic antifungals. As I mentioned earlier, fungus is a normal component of the oral cavity, but when it presents as an overgrowth, it causes an infection. It's also known as candidiasis, oral thrush, or monoliasis, and the underlying infector is Candida albicans. A fungal bloom usually occurs when something alters the balance of the ecosystem. Candidiasis often presents with the following conditions: antibiotic or corticosteroid use, HIV/AIDS, denture wear, diabetes mellitus, xerostomia, hypoparathyroidism, and is often seen in infants because of an underdeveloped immune system. Oral candidiasis will present in several forms: pseudomembranous, erythematous, chronic atrophic, also known as denture stomatitis, angular cheilitis, mucormycosis, and median rhomboid glossitis. You'll recall that we looked at median rhomboid glossitis earlier. The reason I've included it here is the contrast I mentioned from the white coating is often caused by candidiasis. The treatment for any of the above is oral or systemic antifungals as needed. Pseudomembranous candidiasis is the most common of the fungal overgrowths. When the surface is wiped, it may present with small bleeding points. This is a feature that's associated with this condition. It presents as a white, cottage cheesy coating on the tongue, the vestibule, the softer hard palate, or gingiva. Erythematous candidiasis is just that. It is a red form of the lesion. It may be either localized or generalized and will present as painful, shiny, reddened tissue. Chronic atrophic stomatitis, as I mentioned, also known as denture stomatitis, is going to become increasingly important to the dental hygiene clinician. With an aging population of clients wearing dentures for 20, 30, or 40 or more years, denture stomatitis becomes a concern. This is an erythematous lesion that follows the pattern of the full or partial denture coverage of the tissue. That's a defining characteristic of it. It may be either smooth with small punctate lesions or petechiae, or may be granular. It tends to present generally underneath the denture. It's most commonly seen on the alveolar ridge or the maxilla and palate. This lesion may go on to become hyperplastic or overgrown tissue. Angular cheilitis is a condition found at the angles or corners of the mouth, also known as the labial commissures. It can be found on its own or in addition to generalized oral candidiasis. The most common cause, again, is Candida albicans. There may be a nutritional deficiency component, but this is rare. Traditionally, it was thought to be vitamin A deficiency, but the scientific literature has ruled that out as the primary cause and implicates Candida. It may present as redness with or without fissures or cracks at the corner of the mouth, and may be contributed to by oral fluids pooling at these corners, particularly for those clients wearing complete dentures. Mucormycosis, also known as phycomycosis, is a rare and serious fungal condition. Mucormycosis is found as a normal component of soil and is usually non-pathogenic, but becomes so in those that are immunocompromised, particularly HIV clients. Diabetics or medically compromised clients may also suffer from this condition. This fungus may invade oral and nasal cavities, the maxillary sinus, or the hard palate, and become extremely destructive. Biopsy would confirm this condition. The treatment may be surgery to excise the infected areas and a systemic antifungal. The next category focuses on conditions that have a tie to immunity. Although HIV/AIDS is initiated by a virus, it acts directly on the immune system, impairing it severely. The infections that may result as opportunistic can be either bacterial, viral, or fungal. Some of the lesions you'll see are related to sensitivity reactions to chemicals used in the dental office. All of the lesions have some connection to the immune system. Autoimmune disorders and their oral conditions will also be covered in this section. Lesions of immunological origin, again, will become increasingly important to the clinician in the next 20, 30, and 40 years because of the rising number of aging clients whose immune systems will deteriorate and the number of clients presenting with immunodeficiencies caused by HIV/AIDS or other conditions. Immunodeficiency is classified as a deficiency in the type or the number, function, or interaction of white blood cells or their products. It is also present at birth until the infant develops an intact immune system and it matures. Immunodeficiency may be inherited or have a congenital component or be acquired. HIV/AIDS is a pandemic example of immunosuppression. Autoimmune disorders, which are included in this category, would be diabetes mellitus, for example, rheumatoid arthritis, or lupus erythematosus, among others. The current statistics from the World Health Organization as of November 2006 state that 39.5 million people are currently infected with HIV. 4 million became infected this year. There have been 3 million AIDS-related deaths this year, and 6,000 people per day become newly infected. Within 15 to 20 years, HIV/AIDS will be the #1 killer in the world arena. Recurrent aphthous stomatitis, or RAS, is one of the most commonly seen oral conditions. It presents as an ulcer or canker sore anywhere within the oral cavity and is also referred to simply as an aphthous ulcer. 20% of the general population and 57% of professional school population, please note dental hygiene students, will suffer from this condition. RAS are classified as either minor, major, or herpetiform and present as an ulcerated depression with a red halo surrounding them. These lesions are seen more frequently in females. Trauma is the most common initiating factor. Dental hygiene treatment, Some foods, particularly citrus, or anesthetic injections may precipitate an outbreak. Ulcerative bowel disorders are often associated with recurrent aphthous stomatitis as oral lesions. These lesions are eased by the use of chlorhexidine gluconate, as much of the pain is caused by bacterial irritation of the ulcerated tissues. Contact dermatitis or mucositis is a type 4 or delayed hypersensitivity. It's a cell-mediated immune response and results from direct contact with an allergen. It will present clinically as an erythematous, shiny, and then later ulcerated lesion that then becomes covered in a rough white epidermis or epithelium. Some source examples that would produce this dermatitis could be topical medications, preservatives in local anesthetics, dental resins, metal alloys, flavoring agents in mouth rinses or toothpastes, and chewing gum or perfume. Erythema multiforme traditionally presents as vesicles or bullae, which are large blisters, but may also present as a macule, which is a flat lesion, or a plaque-like lesion. They're often found on the lateral borders of the tongue and may present with labial bleeding or crusting. It is more common in young persons with a greater frequency in males. The blister or bullae would present as target or bullseye lesions with a dark center, and this is a defining characteristic. The cause is unclear, but again may be a hypersensitivity reaction. The treatment for many of these conditions will be topical or systemic corticosteroids as needed to suppress the overreactive immune reaction. Lichen planus is another commonly seen lesion. It may present either as a reticular or network-like lesion or may be erosive. On the gingiva, we term lichen planus in its erosive form as desquamative or desquamative gingivitis. Lacy white lines called Wickham striae are often found in the buccal mucosa and will present as chronic oral or skin lesions. 1% of the US population, usually adult clients, will have lichen planus in their mouth. There is a slight female predilection. Lichen planus, in its reticular or network form, is usually asymptomatic, but if it's erosive, may be painful and sensitive to certain foods or liquids. The erosive version may be associated with an exacerbation or worsening with hormonal or stress changes to the system. Treatment for erosive lichen planus is a topical steroid. Periodic biopsy is recommended for clients that present with this chronic condition, as research supports that they may be at a slight increased risk for squamous cell carcinoma. We've included the autoimmune disorders in this category, of course, because they are immune-related. The first that we'll discuss is Sjogren Syndrome, an autoimmune disease affecting salivary and lacrimal or tear glands. The client presents with xerostomia. Because of the excessive dryness of the mouth, they are at risk for periodontal disease, caries, and candidiasis. The parotid gland and its enlargement is implicated in 50% of the cases. The lips may be dry and peeling or cracked. Clients may also come to the office with Raynaud's phenomenon. This is characterized by poor circulation in the extremities. 20% of those with Sjogren syndrome also have Raynaud phenomenon. Clients may also have arthritis and autoimmune disorder in addition to the above. Clients must maintain excellent oral hygiene, may require fluoride to reduce the chance of caries, and other symptoms are treated as needed. Systemic lupus erythematosus, or SLE, is 8 times more commonly seen in our female clients. It has an unknown cause and is progressive or chronic and very complex. 85% of the clients will have a skin lesion. Many are oral. A common characteristic of SLE is the butterfly rash found over the bridge of the nose. Clients again may present with arthritis, Raynaud phenomenon, fibromyalgia, heart conditions, or psychiatric conditions. The treatments include non-steroidal anti-inflammatory drugs, the anti-malarial prescription medication, or corticosteroids. Pemphigus is a severe skin condition that also has an oral mucous membrane component. It is progressive, painful, and complex. Blisters form within the epithelial layers. It has no specific sex or age predilections, and 50% of the clients show their first signs as oral blisters or bullous lesions. The lesions vary in size, and even gentle retraction of the tissues with a mirror can produce a blister. Diagnosis is made through biopsy and cellular examination. The treatment is systemic, high doses of immunosuppressive or steroid medications. Mucous membrane pemphigoid is also known as cicatricial or scarring pemphigoid and is similar in some characteristics to pemphigus. This condition, however, is the gingiva. It varies from simply redness to the ulcerations mentioned earlier. This condition occurs because of a breakdown between the epithelium and the underlying connective tissue and causes a subepithelial blister. Like many other conditions of an immunologic origin, it will go through periods of exacerbation and remission. The diagnosis again is made through biopsy, and treatment again is topical or systemic steroids. Many of the oral tissue injuries that you're going to see will be diagnosed by the dentist and assessed by you based upon the client's history and self-reporting. Questioning the client may be able to help you determine the underlying cause of the lesion. Traumatic lesions are usually accompanied by an inflammatory response to a mechanical, a chemical, a thermal, or other trauma. Traumatic lesions that are repeated or recur are of concern to us as a clinician because there is literature that supports that repeated injuries to the same areas may result in cellular changes that can become premalignant or malignant. These lesions need due attention. For those traumatic lesions that are perplexing, keep in mind that the biopsy is the only way to determine their underlying cause. The first of the oral tissue injuries I'm going to discuss with you is meth mouth, caused by chronic methamphetamine or crystal meth use. Rampant decay is a defining or distinguishing feature of this condition. This is one of the newer oral conditions that clients may present with, and it's important for the dental hygienist to have an idea of what he or she might see when meth mouth presents. Oral burns are a particularly unfortunate lesion. The first that we'll look at is the electrical burn. This is often seen in infants or toddlers where they've chewed through an electrical cord or have placed something live in an electrical socket. Most of these are completely preventable, and that's why we child-proof our homes for exactly this kind of lesion. Another common burn is aspirin burn. Aspirin burn occurs when a client places the aspirin directly on the tooth or the tissue causing the pain. You can see a similar lesion with acetaminophen burn. Both are slow and painful to heal. Treatment is to take care of the symptoms in the offending tooth. Another oral burn can be chemical. A chemical burn may be caused by phenol or other chemicals coming into contact with the oral tissues, many of which are found in the dental office. Phenol, for example, is used to disinfect the cavity prep or to cauterize tissue. Phenol is also found in some over-the-counter products used for oral pain, and clients have to be advised that overuse may result in a burn. The traumatic ulcer may be the most common lesion seen by the dental hygienist in practice. Clients frequently bite their tongue or their cheek or their lip. Factitious or non-functional habits may traumatize the gingiva. In cases where the injury is chronic, clients have to be advised that repetitive healing and injury to a tissue may result in cellular changes in the future. A hematoma is the scientific name for a bruise, an oral bruise that is. It's usually traumatic in origin and may present as a red or bluish or purple lesion. It may be swollen as well and will vary in size and location based upon the underlying cause. It's often seen on the buccal or labial mucosa, the floor of the mouth, or the soft palate. It should resolve uneventfully. Nicotine stomatitis presents as small raised lesions on the palate. Keratinization of the periphery or edges of minor salivary glands causes the raised pattern. Inflammatory changes block the small openings of the gland. Nicotine stomatitis may be present with or without dysplasia. It's associated with heavy smoking or tobacco use. Although nicotine stomatitis is classified as a benign lesion, because of the tobacco use and its increased risk for oral cancer and lung cancer, these lesions need to be monitored carefully. Of interest, they will subside once the smoker has quit. For our clients who chew tobacco, there is a condition called chew tobacco keratosis. It's characterized by a keratinization in the mucobuccal vestibule where the tobacco lies. This is also known as a leukoplakia and is due to the hyperkeratinization of the tissue. It may also have a ridged surface. This is of oral cancer risk. Chew tobacco keratosis is also an oral cancer risk. It has now been banned in some professional sports because of this. Actinic cheilitis or cheilosis is a condition caused by excessive exposure to the sun on unprotected skin. It's also known as solar keratitis. The defining feature of this lesion is a crusting or peeling of the lower lip. Also, the vermilion or red border of the lips may become pale and patchy in color. The concern with actinic cheilitis is that it may lead to dysplasia or cell disorganization, and smoking increases this risk. A mucocele or a ranula are caused by salivary fluid pooling in glands or surrounding tissues. A mucocele is caused by this pooling in soft tissues when a gland's duct has been traumatized. It's often seen on the lower lip and may be bluish if it is superficial. This needs to be included in the differential diagnosis because it is similar to mucoepidermoid carcinoma in appearance. A ranula, which is similar in clinical appearance to the mucocele, is often caused by sialolithiasis or a salivary stone blocking the gland. However, is found more commonly on the floor of the mouth. This is an occlusal image of the mandible. You can see on the client's left a small calcified radiopaque lesion. That's a salivary stone and is blocking a submandibular or sublingual gland. Our last lesion today is the pyogenic granuloma and isn't truly a traumatic lesion, but is included in the group because it is a connective tissue hyperplastic overreaction to injury or bacterial insult. For example, cutting the tissue with floss or your toothbrush or a little piece of food may initiate this lesion. It's characterized by bleeding easily, may be red, bluish, or purple in color, and is most commonly seen on the gingiva. A pregnancy tumor or an epulis is an identical lesion to the above, caused by plaque inflammation and made worse by hormonal changes. I hope you found today's review of oral pathological lesions helpful to you in your day-to-day practice, and that you'll find it valuable when you come across that lesion that just causes you to pause for a moment and ask yourself, what could this be? Thanks for joining me.
Pathology Review for the Dental Hygienist has been presented by Carol Barr Overholt, RDH, specialist in oral pathology and professor at Niagara College School of Dental Hygiene.